Okay. Yes, thanks for joining the presentation. I'm Dr. Grant Brenner from Brighter Neurotherapeutics, and I'm going to be talking about transcranial magnetic stimulation, standard treatment approaches, emerging clinical approaches, neuroscience, and some neuronavigation and AI-driven technologies that we're starting to have available. Okay, it's a very exciting time for interventional psychiatry. So I'm pleased to be giving this presentation. Okay. So a little bit about me. I trained in psychiatry at Mount Sinai Hospital. Prior to that, I did 2 years of general surgery and really liked procedural medicine, but felt a real calling to work with people. And the human experience has always been really something that I loved a lot. As a kid, I actually wanted to be a psychoanalyst. And after training, I did do psychoanalytic training and have gone on to get additional training in trauma and dissociation treatment, certificates in TMS. I'm currently studying AI in healthcare. Highly recommend the Johns Hopkins 10-week certificate course for that. And I do a fair amount of not-for-profit work in disaster mental health. I'm on the board of Vibrant Emotional Health and have written or co-edited a few books there. And I love doing kind of public-facing things. So I blog, podcast, and have written some self-help books about dysfunctional relationships. The most recent one is a kind of a multiple self-state, compassion-based model for individuals called Making Your Crazy Work for You, From Trauma and Isolation to Self-Acceptance and Love. I think it's a good book. Check it out. And I'm giving this presentation for the practice. I'm not getting any compensation. I don't represent the company, but I'll mainly be referring to the NeuroStar therapy equipment, which I've been using since 2010 when I started doing TMS. And so that's about me. So TMS stands for transcranial magnetic stimulation. Transcranial meaning it crosses the cranium, the skull. And it uses a pulsatile magnetic field, which is about 1.5 Tesla. By comparison, an MRI is 3 Tesla. And it's strong enough that it causes neurons to fire or depolarize. And TMS has been FDA approved for depression, for treatment-resistant depression since 2008. And has now an indication for OCD and a lot of effective off-label indications. It's extremely safe. And we'll get into the details there. It has no systemic side effects, and it is non-invasive, meaning that unlike some surgical procedures for depression, like deep brain stimulation, it doesn't require any incisions. And it is not ECT. ECT uses direct current to cause a generalized seizure. And ECT requires sedation and anesthesia, which often causes problems at least the day of the treatment. TMS is completely ambulatory. So patients might have a mild headache or nausea in rare cases afterward, but there's no sedation, there's no recovery period. People can come in and just go back to work or whatever they're doing. And TMS targets specific areas in the cortex. So because the magnetic fields get weaker, distance from the magnet, we can only treat and reach cortical areas. And so I'll talk about how do we get to deep brain structures through cortical windows, is what they're called. Okay. The depression focus has been historically the primary focus of OCD because it's a huge problem. It's closer to 300 million people in the world. In the US, over 20 million people are estimated to have major depressive disorder. Many of them are treatment resistant. Only about half of them are diagnosed and a quarter of them are adequately treated. The treatments we have, we'll talk about, are partially effective. And so having a really powerful and effective tool like TMS is a really important addition. Okay. And so what patients experience with TMS, they come into the office, they sit in this comfortable chair. You can see there's a magnetic coil. This is an electromagnet that's inside of here. It's in the shape of an 8, a figure of 8 coil, it's called. So it makes a shape like that. There's some magnetic coils that are circular. There's some that have different geometries. You may have heard of deep TMS, which is like a helmet. That's more actually broad. It covers a broad area of the cortex. It's not particularly targeted, and it gets a little bit deeper into the cortex, but really not that much deeper. And it's limited by not being as targetable. And so people get set up for treatment with something we call determining the motor threshold. So first we stimulate what's called the motor strip that controls movement, and we look for activation in the muscle groups in the hand, and that allows us, number one, to set the magnetic field strength for the patient, which is when there are 50% of the pulses cause a depolarization, cause neurons to fire. That's what we benchmark the treatment strength against. And we can also use that to locate where to treat. So just forward of that, about 5 centimeters, is the treatment area for depression, though there are other ways to localize that we'll talk about. And patients get the treatment session. The standard treatment session is 20 minutes. There's theta burst, which is a 3.5 minute protocol that we also often use, that is shorter. And people can get right back to whatever their regular activity was. During the treatment, it's often it's an unusual experience for people because there's no good way to describe what it's like. Sometimes it's uncomfortable, sometimes it's a little painful. That almost always gets better pretty quickly, and it only lasts during the session. That's the main side effect that people experience. Sometimes it can activate the facial muscles, cause a little tearing, sometimes some discomfort in the teeth. We can change the orientation of the magnet, and as I said, almost everyone gets used to it, and it's fine for them. Rarely someone has a lot of difficulty. If they have difficulty because it's too uncomfortable, we can also use alternative treatment areas that are effective and less comfortable. But we start with the best evidence-based treatment. And so let's get into some of the specifics for a second. In terms of the specifics of medication treatment, what we see from large trials of medications like the STAR-D trial is that with each successive medication treatment, the chance of having a remission goes down and down and down. So all told, with psychiatric meds for depression, remission rates are 36% across all medication trials. If you break it down, 1, 2, 3, 4 plus meds, you see a little less than 30% response rate, remission rate with the first medication. Response rates, are always higher than remission rates. And then as you go to the second medication, you're down to 21.2%, then 16, and then less than 10% by the fourth medication. At the same time, the risk of side effects goes up and treatment adherence goes down with repeated trials of medications, because people always start with medications they think will be better tolerated. And as you add older medications or more medications, there's a greater risk of drug interactions and side effects. So TMS, much better to add it in early if you can, because it's effective, well tolerated. When it works, it will save people many, many months or years of this treatment path. And in the cases where it doesn't work, they still have that alternative. The first study comparing medications directly with TMS was done and published last year. They looked at 89 patients who had failed at least 2 medications, all of whom were in therapy, and they gave them standard TMS, which is a 4 to 6 week course of once a day. We'll talk about accelerated treatments that can be given in a week or even shorter in a little bit. But the standard treatment, which is effective but not as effective as accelerated treatments, still was 5.5 times more likely to lead to a remission than additional medications after 2 failures, and 2.6 times higher to get a response rate, which is at least a 50% improvement, which is still significant. And the remission rates and response rates were respectively, for remission, 27% for TMS versus 4.9 for a third, fourth, or fifth medication, and so on. And response rates were nearly 40% versus about 15% for TMS versus meds. So this was the first direct comparison that showed the superiority of TMS with meds. In terms of what's happening in the brain, if you look at this as a classic PET scan of the brain, it shows in depression there's global lower activity across the cortex and in deeper brain structures compared to non-depressed people. When we give people TMS, this is a 2008 study, we stimulate the dorsolateral prefrontal cortex, which is a key executive area in the brain. I'm just going to move the little window over so I can kind of see that part. So we treat the left dorsolateral prefrontal cortex. That's the cortical window. And you can see here in the middle bottom image that, and these are patients who have an antidepressant response that is sustained after the TMS has been completed. These deeper brain structures, like the anterior cingulate cortex, which is related to the well-known area 25 for treatment-resistant depression, is networked to the superficial brain area and remains more active. And again, what's happening here is there's magnetic field is generated in this coil by electricity circulating in this figure of 8 pattern. The magnetic field is going this way into the treatment area, and then it's inducing an electric field parallel to the magnetic field, and that's called Faraday's law. If you remember high school, the right-hand rule, and that's causing neurons to fire. And then those neurons fire in the local area, and they're connected. The Hebbian doctrine in neuroscience is neurons that fire together wire together, and then we see this distant effect. And you might wonder, well, what other effects are there? So this group was Kido et al., which is a Japanese-based group in 2008. There's a study from 2020 where they looked at brain networks. So there's this 3-network model of the brain, which is a very useful model to be familiar with. The big 3 brain networks are the central executive network, the default mode network, and the salience network. So the central executive network, which is also sometimes called the executive function network or the frontoparietal network in anatomic terms, is like the executive function of the brain, or what I'll talk with patients about is kind of we're helping the CEO of the brain. And in this study, after only 2 weeks of standard TMS, 10 sessions or so, there were statistically significant increases within the central executive network and trends in the default mode network, which is like the resting state of the brain, the wandering mind, which we know that a lot of people have a lot of stuff going on when their brain isn't doing anything that isn't helping them. Like with PTSD, depression, OCD, there's a lot of intrusive thoughts just at rest. And the salience network also had trends that were towards significance. And the salience network is where what we're paying attention to in our own minds. And we need to be able to direct what we pay attention to. So when people are depressed, anxious, etc., their attention gets hijacked. The salience network is pulled to things that we don't want to be necessarily thinking about. And when we restore executive function, for example, with TMS, then that ability to direct attention is restored. And that there's lots and lots of things that are going on, but that's a big picture. And then finally, in terms of the neuroscience here, and this was just published by that same original group, Kido, from 2008. They've been busy over the last couple of decades. They looked at the causal dynamics underlying multiple changes from TMS. They treated patients with depression with TMS, did functional magnetic resonance imaging, fMRIs, compared them with normal controls, and they found a range of brain areas that were affected when we treat the superficial region that were causally significant, meaning abnormal activity in these brain areas. Sometimes it's hyperconnectivity, sometimes it's low connectivity was going on. And what that means, because it's causal, it's not correlational, that means if we are able to influence these areas, we expect to see clinical improvement and changes in brain function. And we can affect them through the surface of the brain. It's worth noting there's other neuromodulation coming into play clinically. One of them is called transcranial focal ultrasound stimulation, TFUS. And like you can use a magnifying glass to focus the rays of the sun to a point, you can use a ceramic acoustic magnifying device, so a small thing that goes on the cranium, to focus ultrasound. And we can target deeper brain areas with that to either increase or decrease activity. And so you can easily envision using a combination of treatment modalities to address deeper and more superficial brain regions in order to really influence these networks and shift them in the direction of what we want them to be doing. So in network science, we would say there's disconnectivity is the problem. And I like to say when we fix that, it's sort of like doing network surgery. It's restoring U connectivity, like euthymia. Okay. And we can start to use neuronavigation. So I mentioned we localize the treatment area for depression, either related to the anatomy of the motor cortex, or we use EEG techniques we can measure the dimensions of the cranium and calculate the treatment area. Those are actually quite precise. In some cases, we would want to actually load a patient's MRI into a machine, figure out what was going on, figure out their individual circuitry, and then pick treatment areas that are more likely to work. And so there's a way of doing this for depression, for example, where we look at the connection between the dorsolateral prefrontal cortex and this SG25 or anterior cingulate area, and we find where they're the most reverse connected. So when one is high, the other is low. It's an anti-correlation. Or you can look for when they're correlated, like a positive correlation. But when you find the area that has the highest inverse correlation and you treat that area, you can get better responses. And sometimes you want to do that in depression, though the non-navigated treatments are quite effective for things like OCD, PTSD, certain anxiety disorders, maybe bipolar disorder, for things like schizophrenia, addiction, pain, and for rehabilitation after strokes and traumatic brain injury. It's really important to be able to neuronavigate using a patient's specific brain image. And so we have a device called the Visor 2 in my practice, which allows us to do that. And I'm not going to go into too much detail, but it involves loading the patient's MRI, analyzing it, and using 3D camera techniques to match the patient's actual head with their brain scan. And then it uses infrared navigation to exactly put the magnetic coil on the exact spot that corresponds to their MRI where you want to treat them. And that's really fascinating work. That is really cutting edge. And I'm happy to talk about that more offline. Okay. TMS is not indicated for reducing suicide, but the research we have shows that, number one, it does not increase suicidal thinking the way antidepressants can. And there is a fair amount of research that it reduces suicidal thinking. And I've seen that in the clinical practice. A number of people with chronic SI has just gone away. But for example, compared to Spravato, intranasal esketamine, which has an indication for immediately reducing suicide, we don't quite have a protocol worked out for that in terms of acute suicidality. But generally speaking, we see that suicidal thinking, often chronic suicidality, really just dissipates. I had a number of patients who've just been plagued with chronic self-destructive thoughts, and they've just gone away. It's great. So that's a note on suicide. And so I'll just pause and catch my breath for a sec. Any questions or comments? I see something in the chat. Let me take a quick look. What's the difference between remission and response? Response is a 50% improvement as measured by standardized rating scales. Remission is treatment to the point where the patient no longer meets criteria for major depressive disorder in this case. And we use rating scales to measure that in addition to clinical evaluation. And I will get to adolescents in a sec. And so for patients, it's often helpful to think of it as like physical therapy for the brain. Just like if you had, I had shoulder surgery, you have to exercise in a certain specific way. TMS is targeting this particular area that helps the brain. But the psychotherapy and the follow-up, just like rehab after surgery, is critically important. And if you're interested, I wrote a piece on my blog about TMS-assisted psychotherapy, mainly been studied with structured short-term therapies and meditation. But what I've seen as an analyst with patients, and I have seen that people's self-reflective function often dramatically improves. And patients, even who have been in years of therapy, who just reach a certain point where their insight isn't there, start making these connections, and they start to develop on new levels that they just couldn't get to before, no matter what. And even with good medication treatment and long-term therapy, I've seen TMS shift the patient's developmental trajectory. And it's on my mind because I have just seen a couple of people who are just doing phenomenally, and they were going like this for years, and then TMS, they are on this developmental curve. It's almost like you could almost think of it as a regenerative medicine. It's almost like it resets the brain to an earlier developmental level where they can start to engage in personal growth in different ways. And so it's a lot to think about there in terms of not just the TMS treatment, but this rehabilitation and long-term recovery model, which I think we really need to combine with interventional techniques and therapy. Okay, and let's see. So to that question, with standard TMS once a day for 36 sessions on average, the overall response rate is over 80%, and the remission rate is above 60%, which is quite a bit better than medications and even therapy. Accelerated protocols are coming online. The SAINT TMS protocol, which is neuronavigated, was approved in 2022. That is where you use that anti-correlation I was talking about to find the specific treatment area. But we can do a very similar protocol without neuronavigation, and 36 sessions are given to people within a 1 week period of time, and they do very well. Often after the first day or two, we see significant improvements. And it's really shocking to people because they may have been depressed for 10, 20, 30 years. And after a day or two, they come in, they're like, I'm feeling better. Is that possible? And I've seen it over and over. We actually have a study of accelerated TMS. We're one of a few centers doing an open label trial. And so we can offer that at a reduced rate for study participants. And you can reach out to us if you have anyone you'd like to refer for that study. Again, extremely safe and effective. And we would love to work with patients and could definitely talk more if you have specific referrals for the research study. Okay. And we can use some of these accelerated techniques for other conditions as well. It seems to be the case that the total number of treatments of TMS is a big predictor of outcome. So more is better, and the more you can give in a shorter period of time also seems to give people a stronger response. So we can give 36 sessions in a week. You can give 50 sessions in a week. There's even a protocol where people have 20 sessions in a single day, and that can be augmented with certain medications as well. So our understanding of the techniques and the combinations to get the maximal response is really essentially there's advances, every month or so. For adolescents, there's a terrible, endemic problem with depression and anxiety. I'm a father of teens. I've seen it with their friends and the family. And TMS has gotten an approval for treating adolescents 15 and up for depression. Based on a large number of pooled data of patients treated over the years, almost 170,000 treatments. And adolescents see about a 50% response rate, 50% remission rate, and almost 80% response rate. And unlike with adults, where people have to have failed at least one or two meds to get insurance to cover it, at least for the FDA clearance, it's approved as a first-line treatment as an alternative to medication in teenagers. So again, you have this opportunity to potentially reduce the burden of long-term medications. If TMS works, it's great. If it didn't work, you can still do the other treatments as you would and combine it with therapy 100%. Okay. The next question is, well, how long does it last? So the majority of people we treated don't need any kind of booster or maintenance, but some of them will start to dip down again. Their depression comes back a bit, or they have anxiety that we want to target that requires a different protocol, and medications aren't helping with, and they can't get traction with therapy, et cetera. And we'll do a booster treatment if we start to see their depression coming back. And that's usually 2 days of accelerated or about 2 weeks of standard treatment, about the same number of sessions. And the majority of people will respond well to a booster treatment. And then if the depression keeps coming back, we develop a maintenance protocol, which is usually a few sessions a month. I haven't had to do any maintenance protocols in years, but we've had to do a few booster treatments. But the maintenance, unfortunately, is not yet covered by insurance. So we always have to fight those approvals one by one. And there are some more there's some more research coming out on maintenance protocols. There was one that found that a very simple 15-minute treatment on the right side can actually sustain the TMS response as well as lithium therapy can, which is quite good because lithium is a very effective drug. Though lithium may have other benefits that we could talk about in terms of being neuroprotective. There's many studies coming out that even low levels of lithium can prevent future dementia or prevent cognitive impairment. But that's a longer conversation. But it seems to be that lithium is really important for the brain, even in subclinical doses and is maybe absent in our diet the way it is present historically. And I'll just say with lithium, it's interesting because the large epidemiologic studies have found that in areas of the world where lithium is higher in the food and water, there are lower rates of suicide and homicide, for example. Okay. TMS also has an FDA approval for OCD. We often have to duke it out with the insurance companies a little bit to cover this one. The depression is covered quite easily. And OCD is really hard to treat. It requires intensive therapy, higher doses of medications. And OCD is the kind of condition where you'd love to treat it into remission. But if you can get a 25, 50 or better percent improvement, the day-to-day quality of life improves dramatically. It's kind of like the idea of treating migraines. It's hard to treat migraines completely, but if you can reduce the intensity by 50% and the frequency by 50%, the quality of life improvement is huge. And so TMS has a response rate of 70% with significant improvement, but not full remission. And then that's sustained around 57 to 60% over time baseline. And then we need longer term studies. It still is sustained going out over a month for a good percentage of people. And again, I think a lot of that depends on what they do afterward as well, because you get this good response and then people have to really take care of it. It's like, again, like having surgery. If you don't keep up the rehab and exercising, you're going to have problems in those joints or muscle groups. And with OCD treatment, we treat the dorsomedial prefrontal cortex, which is just adjacent to the depression area. And that connects with a different set of deeper brain circuits that ultimately lead to the striatum, which is the condition response kind of habit-based learning area of the brain. And in OCD, there's a few different paths, but the main loop is called the CSTC loop. It's cortico-striato-thalamo-cortical loop. So the part we can treat with TMS connects with the habit center, and then it goes through this kind of switchboard, the thalamus, and back to the cortex. And with OCD, you have a loop which is too rigid, and we can strengthen the parts of the brain that can inhibit that loop. And with some deeper brain things, possibly like the focused ultrasound, we could directly target both the surface and the deeper structures to get a better response. And that would require neuronavigation. Okay, so a couple of final points. I think we are going to have plenty of time for clinical discussions and questions. So for patients, they just have to show up, and treatment at first is unfamiliar, and then every single time, with almost no exceptions, after a little while, a couple of days, people are just like, oh, this is, like easy, right? It doesn't bother me anymore, or it's almost like boring. Sometimes people will fall asleep during stimulation treatments, which we can't let them because you have to be awake. So just to say that it's extremely tolerable and people get into the routine of it. And then one of the added bonuses is that they're coming into the office. And so for people who have had trouble getting out of the house, it's really good because it gets them on track with behavioral activation. And so again, standard treatment, 36 sessions. The more sessions, the better. So if people have had a partial response to 36 sessions, we'll usually apply for more through insurance. They usually approve them 10 at a time. And then we want to really treat as much as we can to get the best response we can. The most serious side effect for people is a very, very tiny risk of a seizure that can happen in less than in about 0.1% of people. We've never had that happen in our practice. The machine we use is very safe because it has a computer dashboard that really forces the operator to not make a mistake. There are other machines which are more operator dependent, where the magnet is just free and you put it wherever you're supposed to by hand. The machine we use has an arm which is locked that's attached to the machine, and the computer guides exactly where to put it using a system on the headrest so that it's very, very difficult, if not impossible, to put it in the wrong spot and cause a seizure. And then discomfort during the session, sometimes activation of muscles in the face happens. And then a few people will have some nausea or headaches around the treatment that are generally time limited, and they can take Tylenol beforehand, that kind of thing. So it's extremely safe and well tolerated. And there's no systemic side effects. There's no magnetic field below the collarbone. So even people with pacemakers, as long as there's not a lot of metal above the collarbone, they can get TMS. So the people who couldn't get TMS might have implantable things in their head. You can have dental work as long as there's not a big plate. That could be a problem because magnetic material can move. If they have aneurysm clips, we're really careful. They're usually titanium, which is okay, but generally speaking, very few side effects and almost no contraindications. And it can help with the depression and bipolar disorder, but we're still trying to work out how to help with the mania. And again, that would be an off-label treatment. But we treated a number of patients with depression and bipolar disorder, and they've done quite well. We haven't seen any switching into mania in the patients I've treated. Okay. And so we talked about the side effects. What I had mentioned earlier is for the less than 1 in 20 people who just find it too uncomfortable, we can also inhibit the same area on the right side of the brain. That can also help with anxiety. And it's also effective for depression, but it's only 1 pulse per second instead of 10 per second. So sometimes we'll switch to that if the standard treatment is intolerable. But again, haven't had anyone who's found it intolerable so far. We're a network with United Healthcare, Optum, Aetna, and close to the finish line with Cigna and Blue Cross Blue Shield. And we're often able to get out-of-network agreements as well as single case agreements. Okay, and I see a bunch of questions in the chat. And I'll just leave this up for a minute. Plenty of stuff to talk about. I'm happy to answer any questions. Do you want to do that Q&A, or I'll go through the chat? Does anyone want to just speak up? Okay, I'll run through the chat then. Okay, let's see, where's the last thing I answered? So yeah, it's approved for adolescents 15 and up. Oftentimes people may treat younger, but it's 15 and up right now. MD, major depression, and OCD are the only on-label treatments. In terms of PTSD, it is helpful for PTSD. There's a fair amount of research on that, and it depends on what the type of symptoms are. So I mentioned for OCD, we treat the dorsomedial prefrontal cortex. That's also often a target for PTSD treatment. And sometimes we also can inhibit the right side of the brain for more like a generalized anxiety presentation. And there are groups that are studying neuronavigation to provide personalized treatments for PTSD. That are very promising, so we can map out the specific brain circuits for that person. And I've treated a lot of patients with comorbid PTSD because I'm also a traumatologist. So I'd say most patients who come in with major depressive disorder really don't just have that as the diagnosis. A lot of times there's developmental adversity, and the complex trauma presentation, I see a great deal of improvement, and people are often able to work through early developmental problems in a way that they hadn't been able to. So I think TMS also helps on that level psychotherapeutically, because it's keeping these brain circuits that are getting in the way from getting in the way. But I also think it's enhancing executive function and self-reflective function. Someone should study that. There are some studies of TMS for dementia. There's a study just came out of TMS for progressive aphasia combined with language therapy. And for dementia, it's hard to reverse the course with TMS because there's this real kind of physiological issue, but you can activate brain areas and help to preserve some of that activity and maintain cognitive function. So sometimes that will involve treating the precuneus, which is a part of the brain that has been shown to be treatable for dementias. TMS and EMDR, I think that's a reasonable approach. There's not much data on it. I think the important thing is to work out what's going to be a good fit. So I'd say some patients will be more on the insight-oriented spectrum, and they make good use of that. Others, depending on who they are, and it really does involve conversations, do better with kind of a structured approach. The only caveat I would have, and often if patients are getting treated for depression, it's not always helpful to do some kind of exposure therapy because it will often stir up feelings that make them kind of feel more depressed. So sometimes it's better to put off the exposure piece until they get to a more resilient place. And that does fit in with like the resourcing phase. So you could kind of conceptualize TMS as being resourcing within the EMDR framework, getting the patient ready to do that work and kind of get them strong for it. And so what I do is I monitor closely. And if something is happening in therapy that is kind of bringing up too much stuff that is interfering, I'll ask like kind of let's hold off on that part. And it's a little bit of like the analogy of the orthopedic surgery. Like if you have your shoulder repaired, you don't want to go out and start like lifting heavy weights. You want to do like the light stuff to get stronger. TMS with depression and anxiety. In some cases, TMS won't address the anxiety, though generally speaking, anxiety improves alongside depression. There's a subset of patients for whom anxiety either won't be treated or sometimes will get worse. And in that case, I will usually add an anxiety protocol. And if it's more obsessional, it will involve stimulating, increasing activity in the dorsomedial cortex, the OCD area. And if it's more anxiosomatic, like nervous physical symptoms, we can inhibit the right side of the frontal cortex and effectively treat anxiety for a lot of patients there. If a young adult has treatment-resistant depression, which is likely, at least in part, a result of child sexual abuse, would this still be recommended? It would be. And for people with trauma, again, even if you only treat the depression and it helps with cognition, I've seen ADHD improve as well. But with PTSD, there's a lot of times there's avoidance, numbing, and cognitive problems. Just treating the depression helps a great deal. And it's an interesting conversation because people will look at their history and kind of feel like I should feel depressed because I went through this bad stuff, or I had a loss of a parent as a child. I should feel depressed. TMS is kind of blind to that because you just are addressing the aberrant brain activity. And so generally will help people who have problems like that. It's rare if someone had abuse and the TMS kind of reminds them of that. You might see that with combat veterans because it makes noise and it could sound like gunfire. You just have to be careful about triggering. Or I've sometimes had people who were restrained as part of abuse and the person is not restrained during the TMS treatment, but we make it clear to them that they're not restrained. If something is triggered, you can get up, stop whenever you want. We can pause because needing to stay still during the treatment will trigger some people with that abuse history. So I'm just super attentive to that and responsive.